Hello everyone, this is Mary Gregory with Mass Coding Solutions. Welcome today. We are going to be continuing in our series where we are talking about things that will help you to be successful on that CPC test. That stands for Certified Professional Coder. That is a test that is administered by the AAPC. I am a licensed instructor through the AAPC. Been coding for many years, just in case some of you all just picked me up recently, or this is your first time hearing Mary Gregory from Mass Coding. Today we are, like I said, we're going to continue our series where we are going through the CPT book chapter by chapter, and I'm pointing out to you things that could hopefully be helpful to you in passing the CPC test. This can also help you if you wanted to pass the CCS, that's my credential, the CPC hospital or outpatient, CPCO I think it's called now, the Certified Outpatient Coder. This can help you as well with that. You have to always remember that the CPT codes, the CPT guidelines, have to be followed by any entity that is billing with CPT. Now, there are going to be times when a facility like a hospital will not use certain CPT codes because it's considered to be a building. And what I mean by that is this. You may have a 70,000 code, one of the radiology code, ultrasound code, CT code, and it may say interpretation or with interpretation. Where a hospital cannot use that code because a hospital cannot interpret anything. Only a physician or a healthcare practitioner that is licensed to make diagnosis or to do that can do that. And so that's what I mean when I say there are some codes a hospital can never use. Now, but a hospital in the outpatient arena, it can be the emergency department, it can be radiology, it could be the lab, it could be wound care, anything that is done outpatiently and as an outpatient, and they want to bill for it, they're going to have to follow the same CPT guideline. Even your ambulatory surgery centers, ASCs, they have to follow the guidelines as well. These guidelines are out there for all. And so sometimes I think we get a picture, or we have this mentality that CPT guidelines are only for physicians. No, that's not true. If you are billing for something that requires a CPT code, you need to follow the guidelines. Well, with that being said, I believe we have done chapter 1, and really in your CPT book, it won't say chapter 1. It'll actually say Integumentary System. Chapter 2 would say Musculoskeletal System. I'm just using chapters to keep me straight in my head and to keep me flowing. So today we're going to be talking about the respiratory system. That's the third section in that book, in your surgical book for CPT. And so some things you want to know about the respiratory system. You always have to remember that the CPC test cannot test you on everything. And I think I heard somebody say one time, these tests are testing maybe what you don't know. I never quite heard that, and maybe I got that wrong. The test is only going to test you on your ability to think things through and things that we see very often. You don't get a lot of questions on procedures that may be done once in a lifetime or once a month, every 6 months. Like, they're not going to give you a case to code where the patient have a total new face put in place. Now, there's a way you can code that, but most of us not going to ever code that. And so they're not going to test you on that. They're going to test you on the things that everybody's doing every day. In the respiratory system, you want to understand what a biopsy is, okay? You want to do your biopsy. You want to do foreign body removal. The main thing you have to pay attention to is where is the biopsy coming from? Or where is that foreign body at? Also, how did they remove the foreign body? Sometimes they just take an endoscope and go up and get the foreign body. Sometimes they can use a little pair of tweezers to get a foreign body. So you always have to be aware of the site of the procedure and how the procedure is being performed. Also, nose procedures. In your CPT book, it is referred to as rhinoplasties. Now, your scenario may or may not say rhinoplasty, but you have to know that rhinoplasty, because rhino means nose, will be or could be the correct code. So always remember, they may not say nose when they're doing a plastic surgery procedure in CPT. Your physician may say nose, but CPT may say rhinoplasty. You want to know about your septoplasty, okay? So remember now, your physician may use the terminology nose. In CPT though, you may see the word rhinoplasty, and you have to know they mean the same thing. I want you to pay particular attention to code 30520, your septoplasty or submucous resection. If your physician said they did a septoplasty and a submucous resection, guess what? You may have two codes. Not exactly sure what's going on today. Also, epistaxis, control of hemorrhage. Huge, you're going to get one of those. You know, did they use packing? You have to know, was it anterior? Anterior mean the front of the nose, posterior mean the back of the nose. If your code says anterior or posterior, then that may be the code you can use for either site. But if the code just says anterior and your scenario says posterior, that's the wrong code. And then I want to get into the sinus surgeries, because you're going to have a sinus surgery to code. They call those functional endoscopic sinus surgeries. FESS. You're going to get one of those. Please pay attention. Go through your, excuse me, go through your operative note. And let me say this. You cannot spend all day in that op note. You have to come to a point where you gotta go into that op note and know what you're going to be looking for. A good way you can do this, you can look at the codes that's been given you. And so that code may say the patient had an ethmoidectomy, the spinotomy. Okay, so you're going to want to look in your operative note and underline if you have that. But you cannot stay in that operative note all day. There are probably some good videos on how to, identify stuff that you really need in an op note. Because some of that is going to be useless information. You don't care how to lay the patient if you're not doing a back procedure or a procedure where that's important. You don't care if they get general anesthesia if they're not asking you to code for the anesthesiologist. See? So you have to learn to get past those things. And so remember, you're going to get a sinus surgery. And go back. I think a lot of people miss this too. Endoscopy is always included in the therapeutic. And so just because your scenario said the patient had a sinusotomy and then he went on to have a maxillary sinus tissue removal, guess what? You don't code that sinusotomy separate. Be careful with that. Always look to see what the rules and the guidelines are telling you in the book. So go through and practice looking and trying to find those guidelines. So you're going to get a sinus surgery. And so be careful with the codes that say with this or without. That's so important. People forget that. See, if that code said with this, then you don't get the code the other one separate. If it said without, then you get the code separate. So watch out for that. The next thing you're going to have is a bronchoscopy procedure. And once again, be very careful with bronchoscopy procedure, because when you're having bronchoscopies, what's going to happen is that physician may say he did a cell washing. Well, cell washing is always included if they did something therapeutic. Maybe they did a lung biopsy. Pay attention to how they do the lung biopsy. Was it a needle? See, did they use forceps? Was that biopsy, sometimes you have an open biopsy, but we're talking about bronchoscopies today. And look at those add-on codes that says, did you do a different lobe? See, sometimes a physician will go into the right lobe, and then he may go into the left lobe, or he may go into the right middle lobe and then the right lower lobe. And so that code, your add-on codes, very specifically tell you that the physician has to go into a different lobe of the lung. So you want to watch out for that. Pay attention also to your thoracoscopy procedures, the video thoracoscopies, the VATS, as they like to call them, VATS, V as in Victor. So your VATS procedure, once again, your thoracoscopy is could be diagnostic, but if they do something therapeutic, like remove a lung, remove a lesion off the lung, then you are going to want to, you cannot code that separate. The other thing you want to be careful with in doing those VATS procedures and doing some of the removals of the lung, they got some very specific conditions, that you have to use that code with. So always go back and look at your diagnosis. See, sometimes your diagnosis will help you to also come up with the right code. So you want to pay attention to that. Alrighty, so we talked about that. You may get a lung transplant to do. Hey, it's going to be a cadaver. Then it talks about the backbench work. See, everything you need to know is here in your book. So take some time to highlight and mark. So let's move on to the cardiovascular system. I would call this chapter 4. This is a huge, huge system. A lot of things is in the cardiovascular. When we think cardio, we just like to think of the heart. But this system, this chapter will actually talk about arteries. They're going to talk about veins. And so you're going to have, this is a big, big chapter. They generally like to give you a pacemaker to code. And so I want you to look at all the rules and guidelines that surround a pacemaker. Whether the single chamber pacemaker, whether the dual chamber pacemaker. If they tell you they went into the right atrium and the right ventricle, that make it dual. See, you have to know these things. Then, of course, you have your defibrillator. Sometimes a patient can, actually, to me, a defibrillator is just a different type of pacemaker. It'll shock the patient if the patient have a very specific type of arrhythmia going on. So your pacemakers, they're going to give you one of those. They may give you a defibrillator. And then they're going to give you what we call them a little bit different in my world, but it's called biventricular pacing in the CPT book. But in the real world, they call it cardiac resynchronization. That's what they call it in the real world. But once again, that is a device that only turn that off. So that's a device that always have to have a pacemaker or a defibrillator. You can't ever put in a biventricular pacing wire without that. So you have two options. 33224 is the option where you're gonna put it on a pacemaker that's already in place. Maybe you put the pacemaker in place first, then you add that. Then you have an add-on one. The add-on one generally going to be used when the patient is having an upgrade. They're upgrading that patient from a pacemaker to maybe a defibrillator, or they may be upgrading that patient from a single chamber to a dual chamber. So watch out for that. They're going to give you a removal. They're going to give you maybe a reposition, and you have to know all those things. So I can't spend too much time on the pacemaker. You may get that patient activated event recorder. It's very simple. They tell you the patient had one. I think you may see it. So watch out for that. And you may get some valve replacements. They tend to like valve replacement. Once again, some of the valve replacement can be done what they call transcatheter percutaneous. So if your scenario talk about going through that femoral artery and putting that aortic valve in, a mitral valve, guess what? That's a transcatheter, okay? Just in case they don't use that word. If they tell you they made a split up in the chest and did a thoracotomy, that's open. So watch out. Sometimes they put a device in, sometimes they do not. So you want to pay attention to that. So those are your valve procedures. You definitely going to get a coronary artery bypass to do. You got to know how to count your vessels that's being bypassed, okay? They can bypass a bad spot in the heart with a vein, or they can bypass it with an artery, or they may want to do both. And that's where you have your combination codes in. And always remember, if your scenario say the patient had a 3-vessel bypass, when you do your bypass coding, it must equal to 3. So maybe he did 2 veins and 1 artery. See? And if you got a combination code that says you did 2 veins and an artery, then that's the code you want to use. See? And it might say 3, it might say 2. But you always have to make sure that your coding matches up with the number of arteries that was bypassed. So I can't get into that too much, but they do have vein only. Sometimes people get a bypass and only use vein. And then sometimes they may use an artery, only an artery. And like I said, sometimes they'll use a combination. The only time you're going to code the removal of the vein or to use as a bypass vessel is when they go do endoscopic. But if they do it openly, no, you don't need to code that. Okay, look out for that. Lots and lots of codes on the endovascular repair of your descending aortic aneurysm, or the thoracic aorta, abdominal aorta. You will see things talking about docking stations and dockings. So you want to pay attention to that. Once again, I can't get into it a lot, but always remember, one of the things in getting these codes right is, are they working on, see, you have to remember your aorta is the largest artery in your body. Part of it is upper, part of it is lower. So the upper part is called the thoracic, the lower part is called the abdominal. So that's what you're going to have to be looking for in your scenario. Are they operating on the thoracic part of the aorta or the abdominal part of the aorta? It's very important that you get that right. And also, some of these codes will tell you why they're doing it. Did the patient have an aneurysm? Did the patient have a pseudoaneurysm? Did the patient have a dissection? So sometimes, once again, you want to look back at your diagnosis because it may help get you into the right place. Alrighty, and then proximal, in the book here, they use proximal extension. So always look to see if the physician document that. Now, they make these scenarios very easy. So usually they're going to tell you in the scenario exactly what you need in order to get the right code. So I can't spend too much more time on that. But what I want to talk to you about too in this area, you're going to have something on aneurysm, thromboendarterectomy. Very simple. Just make sure you in the right site. That's so important. Sometimes they'll give us a scenario and maybe one of the codes or 2 of the answers may have to do with the wrong site. Pay attention to the site. Are they in the carotid artery? Are they in the mesenteric artery? Are they in the renal artery? You have to pay attention to that. Did they do it percutaneous? Percutaneous, you can always tell percutaneous because they're going to tell you they went through the femoral artery, or they're going to tell you they went through an artery in the arm, most of the time the brachial artery. See, once they tell you that, you know you got percutaneous. So if you see 2 codes, 2 answers there for open, you know those are the wrong answer. Alrighty, and the other thing you're going to want to look at is the vascular access device. Very important. It's a lot of good information in your CPT book about your vascular, your VADs as we call them, vascular access device. You got to know how old is the patient, because see, some of these codes by age. Then you got to know, was it tunnel or was it non-tunnel? Was it centrally placed? Centrally placed means up here in the vascular system. Sometimes you get a PICC line. A PICC line can be placed in the arm or leg, so you really have to look at it and know central. Now, they tell you what the central is. You don't have to miss this question. You might say, well, I don't know what the central area. Read the book. There your book. It's tell you. To qualify as a central venous access catheter or device, the tip of the catheter, the tip, not where they start putting it in, like a PICC line. Sometimes they may start a PICC line up here in the arm, or, I'm thinking about a midline. Your PICC line, once again though, could be in the chance where they doing the insertion is not determining your coding. Where that tip rests in the body determine your coding. And so your central lines, or your central VAD, it tells you it must terminate in the subclavian. If it terminates, in other words, that tip rests in the subclavian up in here, then it's a central. Brachiocephalic, did it rest somewhere in there? Most of the time the tip is going to rest in the superior vena cava, right below it. But anyway, they letting you know centrally inserted. They tell you right here what it is. So you don't need to miss that question. Alrighty? And so once again, there you want to pay attention to age. You want to pay attention to was it tunnel or non-tunnel. Was it a port? Because if you have a port, it's a different code. Sometimes the port can have I think it may be 2 or 3 different codes for the port. So you want to look at that. Your PICC line, once again, a PICC line can be with or without a port. Most of the time in my real coding world, they're without. So I just wanted to bring that to your attention. You also going to have something on hemodialysis. You got to know these codes for hemodialysis. How, not so much how they get into dialysis, even though you're going to have that. But that won't be in this chapter. It's going to be in another chapter later on in the book. But a lot of times they're going to give you a scenario where you have to code the arteriovenous fistula that they're putting in. And you have to know, did they connect it with an artery and a vein? Or did they put in some type of artificial graft to bridge that connection? See, all that's important. And that's what you want to be looking for. When you have a report, don't worry about how the patient is placed and how the patient is getting general and just don't worry about that. You got to say, they want me to code this AV fistula. I need to know, did he connect the artery and a vein? That's what if I do, then I'm going to have to go back over here. Did he make an open incision, or did he use some little catheter to go under the skin and do it? See, all that stuff, that's what's important. And so you have to remember those things. And I won't be able to get the other revascularization is the lower legs. Sometimes they put stenting in. That stent can be drug-eluting. It can be non-drug-eluting. CPT doesn't care about that. Now, if you're doing the CCS, it could be different. But CPT doesn't care about a stent being drug-eluting, bare metal stent, non-drug-eluting. All they want to know is where did you put that stent? Where did you put it? That's what they need to know. And so you can put a stent in the heart, you can put a stent in the legs, and when you get into your peripheral vascular system, you want to read and know about them territories. Iliac, femur popliteal, tibial peroneal, iliac vascular, and the femur popliteal territory. Because see, if they're doing that within a territory, you may not get the coronary stent. Because they consider that to be within the same vascular family. And that's what you got to concentrate on. Is this thing in the same vascular family? So I know I'm kind of going a little bit fast simply because, we can't do these videos very long. You all get tired and bored. So we try to keep them short. And I am going to do one more chapter because it's very short. And that's called your hemic and lymphatic system. So that would make that chapter 5. It's like only 2 pages. So that's why, actually 4. That's why we tend to forget it. Bone marrow transplantation goes here. See, but just because somebody takes some bone marrow out of somebody's bone does not make it a transplant. So you gotta make sure that your scenario said transplant. It could be a stem cell transplant. It can be a bone marrow transplant. They going to go here. And there are times when people may have some eggs preserved. Your cryopreservation goes here as well. So because it's not only the lymphatic system, it's the hemic, meaning blood system. Okay, so a lot of time you want to your transfusion wouldn't be coded here. They code it back over in the cardiovascular system. So if you take out any lymph nodes, you're going to be here. Once again, pay attention to your lymph nodes removal. Was it laparoscopic or was it open? Anytime they tell you they putting a port in, they tell you they made an incision and they inserted the port, you got a laparoscopic procedure. You got some type of scope procedure going on. And so you want to code it appropriately. I am going to end this particular video. I think it's a lot. I've gone pretty fast because I've been trying to get a lot in. But stay tuned because we're going to do 2 more chapters later on. And you don't want to miss that. And, we have a website. Please feel free to visit it. It's MAS Coding Solution, www.mascodingsolution.com. We are on Facebook. We are on LinkedIn. And we also Twitter. I don't tweet a whole lot, but we do tweet. Feel free to reach out to us if you have any questions. And once again, I really thank you for allowing me to come into your home or car, wherever you may be, listening to this video. Just keep us in the loop with you, and let me know when you pass the CPC. Let me know when you graduate and go on. It is so wonderful to hear back from people that tell me that this have helped them in some way, and I really do appreciate that feedback. And on our next segment, we won't do it on this segment, but on the next segment, we are actually going to do a Q&A. We have 2 questions that we want to respond to. That would be a great help to everybody. This is Mary Gregory signing off in the beautiful Charlotte, North Carolina area. Look forward to talking to you real soon.